and welcome to today's Public Health Ontario Rounds presentation on PHO Rounds Hepatitis C in Ontario, testing, direct-acting antiviral prescribing, and implications for hepatitis C elimination. My name is Vanessa Tran, and I'm a clinical microbiologist at PHO, and I have the pleasure of moderating today's session. Before we begin with today's presentation, I'll mention a few housekeeping items. The chat pod has been disabled to limit any distractions during the presentation. So please use the Q&A pod if you have any questions during the session. A discussion and question period will follow the presentation. If at any point during the session you experience any technical issues, please email capacitybuilding@oahpp.ca. I would like to state that as moderator of the session, I did not have any potential conflicts of interest to declare. So before we dive into the presentation, I would first like to provide some background and context for today's presentation, and I'll do this by describing the testing trends for hepatitis C testing in Ontario. Routine laboratory testing for hepatitis C virus is done using serology or antibody testing and PCR testing for RNA, viral RNA. To examine the trend in testing and compare current testing volumes to pre-COVID-19 pandemic testing volumes, we looked at the testing volumes from January 1, 2019 to July 31st, 2021. So a period that encompasses both the pre-COVID pandemic and currently the COVID pandemic. So it's important to note, though, that while this is at the population level, it only represents testing completed at PHO laboratory and does not encompass any testing done outside PHO laboratory. We compared the number of serology and PCR tests by month and determined the percent change in 2020 and 2021 relative to 2019 to look at the difference or the impact the COVID pandemic has had on our testing volumes. Next slide, please. This bar graph illustrates the number of serology tests by month, and each color represents a year. So the blue is 2019, the green is 2020, and the brown orange is 2021. What I hope you can immediately appreciate is that there was a dramatic reduction by about 67% in April of 2020 compared to 2019. So you're comparing the blue bars to the green bar. This coincides with the first lockdown in Ontario. So the testing volume gradually rose over the remainder of 2020, but it still did not reach 2019 levels for the same time period, with reductions of about 20%. In 2021, so now we're looking at the brown bars, the serology testing volumes increased relative to 2020, but still did not reach 2019 levels, with a reduction of about 5 to 20% across the months. What's important is that we do not see a sudden reduction in test volumes as we did during the first lockdown, suggesting that despite the various lockdowns and public health measures, individuals were still seeking care, but maybe not to the same levels. Next slide, please. A similar trend in testing volumes was seen with the HCV RNA testing, with the most dramatic decrease in test volumes observed again in April of 2020. Testing volumes have recovered somewhat in 2021, so again, the brown bars, however, not to 2019 levels. And what's important, not to the same extent as the HCV serology testing. So our percent reductions still remain ranging from 22 to 50%. As a reminder, RNA testing for HCV is done as baseline after a positive HCV antibody result in order to determine the infection status of the patient prior to and during antiviral treatment for hepatitis C, and post-treatment to determine if the patient has cleared the virus and achieved a sustained virologic response. As seen by the reductions in testing volume, the COVID-19 pandemic resulted in restrictions to healthcare. Next slide, please. So testing is only one part of the care cascade for HCV. Today, we'll learn how these impacts to testing and healthcare have translated to access to HCV treatment in Ontario. Next slide, please. So with that, it is now my pleasure to introduce the speakers for today's presentation, Mina Tadros and Natella Constantelos. Mina Tadros, PharmD, is a scientist at Women's College Hospital Institute for Health System Solutions and Virtual Care. He is a pharmacoepidemiologist and pharmacist, and also an assistant professor at the Leslie Dan Faculty of Pharmacy at the University of Toronto, and an investigator with the Ontario Drug Policy Research Network, or the ODPRN. He completed a PhD in pharmacoepidemiology at the University of Toronto and previously completed a master's in health outcomes and policy research at the University of Tennessee and a doctor of pharmacy at Albany College of Pharmacy. Natalia Constantelos is a BSc and is a PhD candidate at the Leslie Dunn Faculty of Pharmacy, working under the supervision of Dr. Suzanne Cataract. Natalia completed her honors Bachelor of Science in Biomedical Toxicology in the Faculty of Medicine at the University of Toronto. During her undergraduate degree, Natalia worked in research at the Hospital for Sick Children, St. Michael's Hospital, and within the Department of Pharmacology and Toxicology at the University of Toronto. Supported by a CIHR doctoral award, Natalia's doctoral research focuses on health services, pharmacoepidemiologic research methods, as well as drug safety and effectiveness. So with that, I would like to turn it over to Mina and Natalia.
Thank you very much, Vanessa, and thank you to PHO for the opportunity to present this this work today and to host this this presentation. And most importantly, thank you to all of those attending. Getting slotted right before the long weekend, I thought that maybe we can sneak this in there and we wouldn't get the number of people showing up. So we're very delighted to see the interest in this topic and our work, and we hope that through this lunch break we can kind of give you some interesting things to digest and work through as we think through it. Next slide. So before we jump in, some disclaimers and disclosures. So the first disclaimer is that whatever we present today is not is not from PHO. This is coming from us as independent researchers and our various different organizations. And PHO is not the owner of any of this content or the information in this document. And so this, if you get mad at anyone, you can send me a note and we can talk about it. But some important disclosures for you to understand: there's no actual potential conflicts of interest in relation to the topic or presentation. But for full disclosure, the work presented here is largely funded by the Ontario Drug Policy Research Network, which is funded with support from the Ontario Ministry of Health, ICS, CIHI, and we've also received some supports from CIHR for some of this work. So the opinions, results, and conclusions reported are of mine and Natalia's, and we're happy to discuss any of those. But again, important to understand where our funding comes from to help support the work that we're presenting today. Thank you. Next slide. So as Vanessa very nicely highlighted in the very beginning, there's an important step in the treatment of HCV that goes from diagnosis to treatment. So in Ontario, we know that over 100,000 people are still living with hepatitis C. And DAAs, as you'll hear me refer to them throughout the next little while, or direct-acting oral antivirals, offer an opportunity to cure chronic HCV. As most of you on this call will know, this was a massive turn in our ability to treat HCV. Prior to that, we did not have any curative type treatments. And so DAAs presented the opportunity in a short course, so short, given 2 to 3 months in most cases, we can actually cure a large percentage. Above 90% of people could be treated and cured, I use that, and cured from HCV. But central to all of that, HCV diagnosis is critical to receiving adequate treatment. And so it was important to kind of think about that dynamic between the two and not just think about treatment in silos. And so commonly, and just to give a little bit of context, with the ODPRN, we look at perspective, as you can imagine, we look at drugs. And so it was hard for us to split it out without knowing where and why people were getting treated and why some people may not perhaps be getting the treatment that they needed. Next slide. We knew that characteristics of individuals prescribed DAAs and the specialty of prescribing in Ontario were largely unknown. These drugs were new, they were being rolled out. They were rolled out in this cloud of how expensive they were. There was a lot of questions about reimbursement, who should be getting them, when they should be getting them. From the drug perspective, there was a big concern that these drugs would be what we termed the budget breakers, in the sense that they were going to cost billions of dollars to invest in and to use to treat. And we actually have a number of papers that have put that number really, really high. So this is, DAAs are considered one of the largest recent investments in healthcare, obviously before COVID, and how to treat something and how to take care of it that's happened for a singular indication and for a specific intervention. And so because of that, the reimbursement mechanisms for how patients got access to DAAs has changed on 2 occasions from the public payers. And I will just note that from some of our previous work, we've found that DAAs, because of their high cost and the populations they treat, are unique compared to other medications that the public payers actually account for, depending on which population you look at, upwards of 80% of all payments. So if you think about how drugs are usually paid for, you would expect that number to be about 50 to 60%, depending on the drug class and who's getting treated. But DAAs, because of their high cost, are largely based on public reimbursement. And so this becomes an important dynamic to understand how the public payers are handling this. We also knew that as treatments were ongoing, we were doing some work prior to COVID, but we knew that COVID would really impact this when we heard murmurings about testing and lockdowns and shutdowns that were affecting, and they were especially affecting those in the most marginalized populations. And so COVID-19 resulted in restrictions to healthcare services as in March 2020, as most of you know, and we were curious about why and how this would affect the trajectories that we were describing. And so whether these changes have modified prescribing patterns and increased access to DAAs to the primary care physicians is really unknown. And so really the crux of this body of work that we want to present to you today is twofold. One, before COVID, we wanted to understand the characteristics of individuals prescribed DAAs in Ontario between 2012 and 2020, and to describe those changes in DAA prescribing physician specialties over the period of time. Bottom line, we wanted to better understand who was getting prescribed these drugs, was there differences by prescriber types, and to start to chip away at if there are some access issues, because we knew not everyone with HCV was getting access to these medications. And so by understanding who was getting them and who they are, we might better understand how to improve upon those. And then the second piece was to determine regional utilization and access to DAAs from across Ontario. We very quickly learned from the very early parts of these works that given the size of Ontario and the variation in populations and access to treatments, that a one-size-fits-all solution that would come out of these would probably fall short. And this is true not just for HCV, but across all disease states. And so helping to develop information on regional differences would perhaps give tools to public health units who are leading the charge in this, and would help to better inform any policies that areas want to do to better tackle increasing DAA uptake. So I'll be presenting the first part, and then I'll be handing off to Natalia to present the second part. So this work started pre-COVID, and we largely started looking at first between 2012 and 2018, changes in DAA prescribing among physician specialties over this period, including the impact of COVID-19, and then we'll present some of that data later on. So I want to ask the group here, what impacts do you believe the COVID-19 pandemic had on DAA prescribing in Ontario? And you've already had a big clue from Vanessa, but we can imagine there. So there should be a pop-up question now. Okay, great. So you can see here that 88% of people believe that they decreased prescribing, and some people believe that it may have increased or had no significant change. So I'll keep you on the edge of your seats, and let's jump into the results a little bit of what we found. But first, to lay down the groundwork, the first part of this was work that we did prior to the COVID pandemic. So this was in 2019, we did this work. And so we looked at a population-based cross-sectional study. We looked at prescribing from 2012, full calendar years, all the way to 2018. We looked in the number and rate of ODB recipients with a claim for Hep C treatments. And more interestingly, we looked overall, but then we looked at prescriber specialty of the initial prescription. So the prescription that they got. Was it from a hepatologist or specialist in gastro, family doctors, infectious disease, or other? I will note that this other is sort of a grab bag. So it may not only be physicians, it can also include nurse practitioners or any other individual who may have prescribing rights to give out these treatments. Next slide. Next slide, please. So what data sources did we use to conduct this work? And I will sort of highlight this really quickly. So the majority of the project work that we present today is using ICS data. And so for those not familiar with ICS data, it really is the idea of putting together claims from a variety of different sources within our healthcare system. So we know we have separate systems that allow us to connect information from hospitalizations and ED visits, physician visits, pharmacy claims, from Statistics Canada on mortality or any other marginalized population measures. And at ICS, we're able to link all of those together. So So for those not familiar, basically what we're doing is we're really, when we say claims, we're looking at receipts. And the idea here is that by looking at different interactions within the healthcare system, we can paint a picture of what's happening to that patient as they interact with the healthcare system. With that being said, there's some huge strengths to be able to look at a universal healthcare system. And for drugs, a large proportion of people receiving these treatments, but there are some important limitations. We can't, the information on how they interact, what their living status might be, how they interact with the healthcare system, how they interact with public health units, information on over-the-counter drugs, information on smoking, obesity, all those kind of things may not be in that data. We are working, and the data is getting better and better over time. And so some of those limitations are actually disappearing over time. But generally, it's a really crude measure to look at the universal sort of setting and look at a high level of what's happening. And this is the information and data sets that in all of the information today we've presented and we've used. And I know many of you are familiar with this because this is an important data source for a lot of the information that we present for research in Ontario. Next slide, please. So here's what we found. So this figure, just to orient you a little bit, is year and quarter on the x-axis, and on the y-axis is the rate adjusted by population of Ontario. The black line is the total number of DAA prescriptions. We counted the first. And then the red line below that is the gastroenterologist. And then the line below that is, you'll see the other is the blue, and the lighter purple is infectious disease specialists, and then that lighter green is family doctors. The vertical dotted lines represent changes in listing strategies. So the first in 2015 was when there was addition of some of these products to the exceptional access program. So that's a prior authorization through ODB. The second is in 2017 when there was a liberalization. So they allowed further access than those who had more severe disease. And then in 2018, we had the addition of the newer products and an expansion or a liberalization of the listing. And so what was interesting that we found is that with each change, you kind of see this pickup of individuals and treatments that happen over time, and you see a large number, with the largest occurring when they finally liberalized the listing and allowed general access in 2017. There was a slight uptick in 2018 as more people got access to different types of treatments, but the largest sort of bang for your buck came in 2017. And what this showed us is that, increasing access or allowing the loosening of the criteria allowed increased access to these treatments. And so that was really important. The second thing that this figure shows is that for a large period of time, specialists made up the bulk of prescribing. So close to half of all prescribing in that time point. Now that delta between the different types of specialists and gastros has obviously shrunk over time, as you can see it. And there's sort of a mixed bag of the use of other prescriber types and infectious disease docs. And generally GPs have stayed the lowest. And that sort of for us highlighted an untapped resource that could be used to try to get more and more access to these treatments and kind of thinking through what the final take-home points are. Now, when we updated these into 2020, we found an interesting and an important finding. Next slide. So this same figure was updated into the third quarter of 2020. So that would be up until August of 2020. And what we see is importantly, that black line dips down rather dramatically. And when we did some statistical analysis to see, was this just the trend of what was happening, because maybe the number of susceptibles has already depleted, we see that it's a statistically significant reduction at that pivot point of when the COVID pandemic was announced. And this was true across all specialists. And it kind of raised an important question of, is there, as we're trying to achieve eradication and access to these treatments at the largest number of people, are we seeing an important hurdle that we're going to need to overcome when we come out of this to try to return back to the treatment patterns and things we were using? Important to note that between 2018 and 2020, there was sort of a flatlining that was occurring. And so, generally we were continuing to have access as programs tried to reach out to people. But I do think that the pandemic has sort of set back on the goals of trying to get as many people treated as possible and the potential goals that are laid out in the blueprints of eradication. Next slide, please. So we took those populations in 2018, and we took the calendar year of 2018, and we looked specifically at what the characteristics of those individuals are. And so you'll see here the columns are, the first is the overall column, then we have the gastroenterologist, the GPs, the infectious disease, and then the other. And what we wanted to better understand to try to inform some of the trends, like I mentioned, there's a big opportunity for GPs to try to step in, but we wanted to know who was not getting treated and who was getting treated. And so I'll highlight some really important differences that we first found that existed. The first stark difference we saw was that it seemed that GPs were, the gastroenterologists were more likely to treat older individuals. And when you think about the HCV strategies that were implemented, these are the groups that are most likely to be receiving screenings, especially among immigrant populations coming from key countries. And so this was a population that seems to be referred more often to gastroenterologists. Counter to that, when we looked at the population, the proportion of those in younger populations, GPs seem to treat a larger proportion of younger patients between the 25 to 34-year age group, and the infectious disease was the same. And this might be associated with some of the characteristics of who these populations are that puts them at risk for living with HCV. And we'll highlight that in the next slide here because it becomes a little bit more obvious about who the potential differences are. So to better understand that, we also looked at income quintile of the neighborhoods that individuals lived in, and then we looked at a variety of different comorbidities. And so without kind of a data dump, but we're happy to kind of dive into this a little bit more, and this has been published and we're happy to share this. You can see that the GPs in infectious disease, half of their populations were those living in the lowest socioeconomic group. And when you add it up, almost 2/3 were in the lowest two groupings. In contrast, only half of those within the gastro group. So that, the gastro group's a little bit more, they treat a little bit more of the higher socioeconomic status, although still the bulk of their patients are in that lowest group as well, highlighting the burden of disease on those living in the most marginalized groups of our society. When we think about the comorbidities, it was really stark to look at HIV populations. Those living with co-infections were much more likely to be seen by an infectious disease or a GP doc. Even though they are a smaller number, they're a complex group. And so you could kind of see that perhaps these GPs and infectious disease physicians are actually within perhaps community health centers, which some of our partners that we worked on highlighted to us, or perhaps living in more urban settings where they might be seeing these types of populations. But generally, another important thing was just looking at those with a mental health diagnosis in the past year. And close to 3/4 in the GP and infectious disease group had that versus less than half in the gastro group. So what this starts to highlight for us is that the patients being seen by perhaps living in, with more complex situations, living in more marginalized populations are more likely to be seen by these specialized GPs in infectious disease, highlighting that these GPs may not be your regular GPs in the sense of like out there in the community, but might be linked with community health centers or might be linked with different treatments or public health units. And the gastro and hepatologists were more likely to treat kind of the traditional type of HCV patients in a sense. And so it highlighted a kind of diversity in who's getting access and who's not, but it also highlighted that there's a potential increase of access for GPs as we think about expanding who they help treat and how to get more and more people treated with DAAs. The last thing I wanted to highlight that was really starkly important, and we're kind of diving into deeper just to kind of spark people's interest, was looking at those who received 3-month course. And so we looked at, we highlighted that as a potential metric of finishing your course, which is important to being able to get the full success rate. And you can see that it was 5% lower in the GP and infectious disease group. But given the comorbidities that we highlighted before, which are associated a little bit more with not being able to finish the course, that was really important. And then when we also looked at the rate of previous DAA so this was a sign of potential failure, we can also see that about 2.5 to 5%, depending on which population, experienced that as well. And so some of our work is taking us in this direction to better understand what are the associations of success, finishing your course, and potentially minimizing the need for retreatment if that does occur. Next. I'll hand it over here to Natalia to dive a little bit deeper into the utilization across regions.
Great, perfect. Thank you, Mina. So we'll now be moving on to our second objective, which is to determine regional utilization as well as access to DAAs across Ontario, specifically in 2019. So in order to do this, we conducted a population-based cross-sectional study over the year of 2019. And our index date for each patient was the date of their first DAA prescription that they received and dispensed through the Ontario Drug Benefit Program. So we had a few different outcomes of interest, and we looked at these for Ontario as a whole, as well as stratified by public health unit. So the first outcome that we had was direct acting antiviral treatment rates. And here we calculated two different rates. The first treatment rate was adjusted by the number of individuals within each public health unit or in Ontario that was eligible for the Ontario Drug Benefit Program. And then the second treatment rate that we calculated was a hepatitis C adjusted DAA treatment rate that was adjusted by a regional HCV prevalence adjustment factor, just to take into account the burden of HCV within each public health unit. Our second outcome of interest was distance to prescriber, to see how far patients needed to travel in order to see their prescriber. And this was looked at as a whole again, but also stratified by visit type, meaning virtual and in-person visits. And then finally, we also looked at the proportion of visits that were done virtually. So we actually created a tool with the ODPRN to illustrate this research, including the DAA treatment rates, as well as the distance to prescriber. And we really hope that this can be used as a helpful tool for public health units to use while they're planning out their healthcare services, as well as assessing levels of treatment and access to care within each respective public health unit. And this is also publicly accessible via the ODPRN website at the link that we have here on the screen. So if you go to that website, this is the first map that you'll see. So here, this map shows the HCV adjusted DAA treatment rates. And in this map, as you can see on the legend, darker shades of blue indicate higher treatment rates. So across public health units, we can see at the bottom here that there was a wide range of treatment rates from 28.2, which was in Northwestern Public Health Unit, to 188.5, which was in the Eastern Ontario Public Health Unit per 100,000 population. And as you can see, general trends in the map, we can see higher treatment rates in Southern Ontario with lower rates of treatment in the North. So now shifting gears to our second main outcome of interest, which is distance to prescriber. So this map here shows distance to prescriber for all visit types. So this includes both virtual and in-person visits. And as you can see on the legend, darker shades of orange indicate higher distances, with yellow indicating lower distances. So there's quite a range that we saw here across public health units, ranging from just 4 kilometers to over 1,000, with Ontario having an overall median of 20 kilometers. And of course, generally, we can see higher distances in Northern Ontario relative to the south. So the next two maps that I'll show you also show distance to prescriber, but this time it's stratified by their visit type. So this map here shows distance to prescriber specifically for in-person visits, meaning that this is a distance that a patient physically had to travel to see their prescriber. And again, darker shades of green indicate higher distances. So the distance to in-person visits had a wide range, again, across public health units, from just 2 kilometers to almost 500, while Ontario had a median of 13 kilometers. And we generally see lower distances in Southern Ontario, especially in urban centers, indicating that patients have physicians that are close and accessible to them. So this is our last map here that is showing distance specifically for virtual visits. So the interpretation of this map is a little bit different in the rest, in that this is not a physical distance that a patient needed to travel in order to see their prescriber, but rather the distance that a patient was able to reach virtually through the use of telemedicine and virtual care. So on the map here, darker shades of purple indicate larger distances. And across the public health units, these ranged from 5 kilometers in Toronto, for example, to over 1,200 in Northwestern Public Health Unit across Ontario, while the province had an overall median of 133 kilometers. And generally, we do see higher distances in Northern Ontario, indicating that virtual care is a really important tool for patients in these areas to access prescribers and healthcare that's not just within their immediate area. So now moving to our final outcome of interest, which is the proportion of virtual visits. So there is a wide range here again among public health units in Ontario, ranging from 0% to over 3/4 of visits being conducted virtually in some public health units, with Ontario having a median of about 17%. While we were doing this analysis, we did notice a pattern that more northern and rural communities utilized virtual care, with urban areas having lower proportions of visits being virtual. So with that, I'll pass it back to Mina for the key findings.
Thanks very much, Natalia. So, we've kind of dumped a lot of data, so we wanted to kind of wrap it up and think through what does this all mean, and how does this tie into what should be done, and how do you interpret all of this? So generally, the first point is that over 36,000 individuals receive DAA through the public drug program. So we've done well in getting some of these drugs out. And helping patients get treated for what is now a treatable, I think this is really important, it's a treatable, lifelong infection, but we do have a tool that we could be using. But we need to highlight that we could do better. And I think there's people who are not getting those treatments. And some of the work that we're going to tackle next is trying to better understand who's not getting treatments. A lot of the work that you saw here being highlighted leveraged testing that's happening in the background to look at indication rates by region, and also, but those who are getting treatment slowly, because we're getting lab data at ICS and we're doing a lot more linkages, we're going to better be able to pinpoint who gets treated and who gets diagnosed and gets a positive test, but we're not getting treatment too. And I think that that'll be really important as we try to increase access to these important treatment, and we try to improve what can happen there. The second take-home point is that there's an obvious impact of COVID-19. And so this is obviously HCV is not the only place that this has happened, but I think this is a really important point for all of us to know. And one of the main reasons that we're hosting this today, there was a 49% reduction in the number of individuals in 2020 compared to previous years. And it was sort of reaching a steady state, and who was getting treatment and the capacity that was there. And so as we aim for that goal of eradication and getting more and more people treated, especially some of those marginalized populations that may not have the same access as the rest of the population, it becomes important to kind of heed this as a second call to action when we start to see the light at the end of the tunnel of this pandemic. Like, how do we get back on course, and do we need to revisit the plans that were there? And I think this might be a really great opportunity for the individuals on this call and for PHO to rethink that strategy based on some of the data that we've been presenting prior to the pandemic, and because of the pandemic, to say, how do we get to eradication, and can we do some changes based on what we're seeing to get not only back on course, but to actually maybe even do better and use it as an opportunity to do that. Like Natalia presented, there is obvious differences in regional variation. Now, we didn't want to just report the number there, and we've put out that tool not to sort of pinpoint how people are doing. We understand that each region has its own challenges, has different populations, has different access issues. And some of the issues we tried to get at, like such as distance, access to specialists, are only the tip of the iceberg of that regional variation occurs. There's countless numbers of studies that have pinpointed that regional variation across the province could be for a variety of different reasons. But we do want that as a tool for public health units to understand what their current utilization rates are, and potentially starting to think through, like, if we redo this analysis in a few years, are we able to shift that given what's happening in that population? The last thing, and I think this was sort of an interesting point for us, was this distance to prescriber. We've heard this time and time again, and working with our colleagues at the ministry, this was actually their idea to look at this, was better understanding what is these distances that people have to travel, especially given that the early results showed that close to 50% of all people had to see a specialist. And we know that specialists are hard to see. They're only mostly in urban centers. They don't work in rural areas. So is that limiting how people get access? And so we did see that. We saw people had to travel very, very far distances. But we also saw an interesting opportunity here, which has been made better by COVID, which is the rise of virtual visits or televisits. And I think that this might be a great opportunity to try to fill that gap, whether it's in supporting GPs through sort of teleconsults, or if it's actually getting access to specialists that patients may not have access to, whether it's the infectious disease doctors, or if it's gastrohepatologists that they need access to. I think that one of the things when we revisit what the new strategy looks like on the other side of COVID, one thing we should consider is what telemedicine and virtual care can help us do in achieving this goal. And so overall, I think just to wrap this up, I think, you know, we've been doing well in getting HCV treatments. We can do better. And I think COVID has given us an opportunity to revisit that and think about how we can use some of this information, some of this data on who's not getting treatment to better improve access and continue to strive for that eradication goal that's been set by many across Canada and also globally by the WHO. So with that, I want to make sure that everyone's awake. We've left lots of time. We finished a little bit earlier here with the data. How can Ontario increase HCV treatments? So you can click a few of these. So increase utilization of virtual care, engage with public local health units to address their unique needs, broaden the types of clinicians that can prescribe DAA treatments, or all of the above. And obviously, if there's another answer that you don't see up here, this is a nice segue into the discussion that we've tried to leave some time. You know, I will highlight that one of the purposes of doing this is also to get feedback on what directions we can take this work, important gaps for the tool. I do want to highlight that tool is open to everybody to use now and is an important mechanism for you to get information, but we're willing to update it and we want to continue to kind of work in this space. So the results are in, all of the above, 89% with a resounding all of the above. And that's sort of what we hope we could paint with this presentation, is that I think for us to tackle and improve DAA prescribing, it's going to take a lot of different tools. And that strategy should probably encompass many of the things that we've mentioned today. So finally, for implications and recommendations, in public health units where patients need to travel long distances to access DAAs, consideration can be given to facilitate access to treatments, including enhancing capacity to HCV treatments in primary care. For example, we've highlighted some important things that in our scans came up, like Project ECHO with Ontario Liver, the Hep C net for ministry-funded hepatitis teams to try to increase that. Increasing referrals to local HCV treatment primary care providers and specialists, so improving that in integration, and increased use of the Ontario Telemedicine Network, OTN, especially now that virtual care codes are more broadly accessible. You know, we don't know what that's going to look like after COVID, but the general consensus is that they're sticking around. And so I think this again presents a really key opportunity to try to minimize that distance traveled, and potentially access to specialists and access to treatment could improve with that as well. We've added some specific readings that we've kind of spent some time, our group has worked on. The first explores sort of the uptake across Canada. We've done some work looking at the COVID-19 prescribing trends led by Natalia. And then we've also looked at how this has happened globally across about 8 different countries that are similar to Canada. Here's our references. And with that, I'd again like to thank PHO for hosting us. I will, sort of like beating a dead horse with this. The tool's up. It's a tool for people on this call who are in this space. Please give us your feedback, whether it's on now or sending us emails after, or letting us know what questions are important to you. We plan to continue to explore this space and to better understand how we can improve access to these treatments. And so your insights and people on the ground who are actually dealing with this would be hugely beneficial in a selfish way, but also to make this better. Please, do use our tool and give us feedback about what information we can add to it that'll be beneficial to you. So with that, I'll pass back to Vanessa to lead us into the Q&A.
Thank you so much, Mina and Natalia, for sharing your very important research and your passion for HCV treatment in Ontario. I think it was a wonderful and very informative presentation. We will now move to the Q&A pod to address some of your questions. So please continue to enter your questions to the pod if you had not already had the opportunity to do so. So as the presentation was ongoing, there was a question in the pod about ministry-funded hepatitis C treatment teams in Ontario, which Valerie from the ministry had answered. For those who haven't seen the chat pod, an additional comment is that the Toronto Community Hep C program, which is a ministry-funded Hep C team, did consult with the ODPRN on this. And I think in response to your questions about what other strategies could help increase access to testing in Ontario, an important point was made that an increase to access to housing would also be important, because without this, it would be very difficult for homeless individuals to engage in care. So a question, so somebody from KFLA PHU says, an important stratification point for us is if diagnosis treatment is in the correction systems or general population. Do you anticipate that might be possible to filter on in your online tool?
So we currently don't have any insights into who is specifically in corrections. Now, the navigation of who pays for that drug, I think, is a bit challenging. I think depending on how long they're there, and if there's some, when we see those claims, I will say that we've limited our analysis to only ODB, and so we don't have access to correction services who have a separate formulary. They pay for drugs in a very different way. But obviously, we do understand that there is a dynamic that occurs there. And often, just like with the private system, there's sort of what we call a coordination of benefits, where people will try to navigate between these two systems, especially for these high cost drugs. I will highlight, and I don't know what's happening in corrections, that in many cases, even those with private insurance, many of us here who may be lucky enough to have private insurance will actually still get pushed to the public program because these drugs are so expensive. They call that claim balancing. They have a lot of buzzwords for it, but basically they're just pushing them to the public payer. So I think understanding that dynamic between them is important. I know, there's another caveat at ICS, there is some work done to get some corrections data. So that thank you for highlighting that. And that's probably a population that we can in the future try to explore better and see what that dynamic is as, whether, as they enter that system and exit it.
Thanks, Ina. So the next question I think I can answer for you. So the question is if there's any plan for reflex testing, so viral load reflex testing for hepatitis C antibody positive individuals, which is happening in BC and other jurisdictions. So this is a great question. We recognize that viral load RNA testing can be a barrier to engagement care for individuals. So we have started looking at the feasibility of implementing RNA reflex testing here in Ontario. So hopefully we'll have some news to share in the hopefully not so distant future. Okay, great comments coming in. So so happy to hear that as we need to keep our most marginalized at the forefront of these discussions, factoring in the social determinants of health and the challenges that come with engaging with hard to reach populations who may be at risk for HCV infections. So question here, are there examples of Hep C testing at the same time as HIV testing or even COVID testing in vulnerable populations or patients living in shelters, etc.?
I think I could try to, I don't know if there's any specific examples on COVID testing and Hep C testing. It's a really, it's an interesting idea. I do know that there are a number of studies that have found that screenings, when combined, when you have the opportunity, have been useful, and especially when trying to reach certain populations. The interventions that seem to work the best in the literature, every intervention is sort of a little bit challenging to kind of compare to the next because there is such a heterogeneity, especially when you look globally. But they generally pop up as having three themes. The first theme is they're often grounded in communities. Right? They know their communities, they're adapted to what's happening there, and they often use community supports, community health centers. They use people who are within that community. The second is that they adapt to the living situations of individuals there. There was a comment before on homelessness and the need and vulnerabilities of that population. Absolutely. I think if you don't account for that, especially when you're trying to reach marginalized population, your intervention or whatever you're trying to do is going to fail. And then the third thing, which is sort of the same theme as all of these, is meeting people where they're at. And I think trying to bring people into the healthcare system versus going to them has proven to be a failure when you demand that they enter the healthcare system for any population. And so, if you are designing anything, whether it's co-testing, screening, whatever it may be, I think it's really, really important to have some sort of reach out, outreach. I think this is like the core of a lot of different interventions that are all successful. So I know it doesn't exactly answer your question about if there's any evidence around COVID testing together, but if there is programs being designed or people are thinking through those, I would try to adapt to those three themes. Again, making sure you meet people where they're at, ensuring that you reach, it's outreach, not pull in. And then the third thing is accounting for those social determinants, I think is really important.
Thanks, Mina. Those are great points. Maybe I just add a little bit in terms of the testing volume. So we do see similar reductions in testing volumes for HIV antibody as well as viral load testing as well. So again, it largely probably has to do with access to care during public health restrictions. And they have been coming up, recovering. What's interesting is that they've been covering, it seems, at a better rate than the HCV testing. So perhaps this is a great point in terms of engaging those individuals who may be at risk for both, like the BBIs, to do testing at the same time. That's a great point. And somebody shared a link to the publication of your article, which is fantastic. Thank you very much. Can I just go back to one of the questions that somebody had asked earlier around publicly funded DAA treatment? I was just wondering, I don't know if you know, what proportion of the treatment that was included in your study is publicly funded? How representative is the data for Ontario?
So the data for Ontario that we use is 100%, right? So this is everything that the government paid for. So by publicly funded, now we don't capture if somebody went through NIHB only, but there is, again, a coordination of benefits, and ODB is the first payer for NIHB populations. Now there is a question about people who may live in border regions. So I know that in some of those, for example, like at the border with Manitoba or perhaps with Quebec, there might be some populations who live across borders or have benefits from across places. We don't quite understand that dynamic. And if there's sort of a, generally, if there's a switch through. Now, I will note that if you do live in that area, it's easier and likely easier on the wallet for a lot of different reasons to probably go through Ontario. And so our sense is that that's probably what's happening. People are being navigated towards Ontario when there is access. Now, if somebody there's seeing a physician in Winnipeg or something's happening where they're being pulled into the Manitoba healthcare system, it's unbeknownst to us, and we don't understand what that gap is. The other gap is people who have private insurance through their work or they're paying for it out of pocket. We know that from a study using IQVIA data, which gives us kind of like the wholesaler data, we know that for this, in Ontario, it was, I think, 75 to 80% of all ODB, all DAA claims were publicly paid for, which is substantially higher than everything else. In some years, it was actually close to 90%. So we do feel like we're capturing the vast majority of individuals that you would probably be testing and seeking treatment. The last group, I guess, is the people who would pay for this out of pocket, whether it's because they don't have coverage. It's very small. Most people are able to go through the Trillium program. For those who are not familiar with it, that's the catastrophic drug program. So when anyone's drug spending goes over 4% of their annual post-tax income, they get triggered. So all of us are covered by this, whether your private insurance covers you or not. So with these drugs costing out of pocket $60,000 to $80,000, I think it's pretty easy to assume, unless they're of the elite, that would probably pass the threshold of that 4% for the vast majority of Ontarians. And so we do see a lot of people coming through that program as well. So and when we looked at the IQVIA data, out of pocket was almost like non-existent, unless they were probably buying it for somebody else in another country or something.
That's great. So that your data would cover the DAA prescribing and
yeah. So I guess, yeah, the take home there is that we believe that our data and what's in the tool probably covers the vast majority of what's happening in Ontario.
Great, thank you. I really liked your two analyses, and I don't know if this is possible, but were you able to correlate the prescribing and uptake rates to the distance? I'm just wondering if the lowest rates were seen in areas where there was a greater median distance.
I'll let Natalia jump in. She's been leading this.
Sure, yeah. So we did explore that a little bit, and our results that we found were actually pretty interesting. It was sort of clustered. So the Northern Ontario regions did correlate with lower treatment rates with further distances away, but the same wasn't true as much for more urban regions.
Interesting. We have another question. So some providers are reticent to treat individuals that are at risk of reinfection, which I think we largely hear in the ID population. Have you thought to expand your analysis to model the effects of the limited use criteria change, regardless of initial infection or reinfection?
That's a really important and great question. And so if you if you remember at the beginning, I kind of tucked in this end part where we looked at those who got retreated and what that percentage was, because we'd heard the same question. So some of the, back to the first comment about did we engage with folks at the CHCs or across some of the ministry funded groups, and we did. And what we kept hearing about is my specialist doesn't want to treat, the specialist in my region doesn't want to treat people who are most likely, right? And they kind of use air quotes there, to be reinfected for a variety of different stigmatizing reasons. And so we thought, well, okay, like, is that actually happening? So are the gastros doing way better in treating people who don't get reinfected? And their rates were actually higher. They had 5%. They had double the rate of people who had to actually get treated. Now, we haven't adjusted all that for a plethora of reasons, but you can imagine that even if you adjusted, that difference might actually become bigger, since we know that those typical associated factors that people are stigmatizing with are in the other groups. So that was the first clue. What we plan to do in the future is look at that by adjusting for all those factors, what those rates are, to better understand that. Now, we do know that when the LU codes were loosened, and that was the very beginning, we did see an increase in access. We have not stratified that by any other patient population subgroup, and that's some work that we're going to undertake in the future. So, if you notice, all the stratifications we've taken have been in the prescriber level. The next step is to see, well, have those changes affected different populations differently? Like, was the uptake different? So we plan to do that by income quintile. We plan to do that by immigrant status, and also by sex. We don't have gender, and then we'll also probably look at age groups as well.
I have another great question here. Would it be fair to say that your data covers the majority of those who received treatment, but not the majority of HCV cases? So there was some data from an MPH student that looked at the HCV cascade of care in KFLA. And one of the findings is that from 2015 to 2019, only 36.6% of those eligible initiated treatment within 18 months. So the question is, how many of those who didn't initiate treatment didn't have coverage?
That is the $1 million question. And that is, if you guys invite me back, I promise in 2 years, we're going to hopefully try to answer that question. So we're currently working through cleaning the OLIS data and the laboratory data and the PHO data, and it's all being linked over. That takes a longer time than I thought it would. And then what we plan to do is exactly that. We want to look at all of those who tested, meet the criteria for diagnosis, and then what proportion of them received treatment. That estimate's really great, because that'll serve as a benchmark. And then we'll probably look across the province and see, does that vary as well? And we'll add that in when we get a chance. But that's for me, that's the North Star question of how many people are we missing, and who are they?
Great, that would be amazing. I'm really looking forward to that analysis. So your trends are really great. How do they compare to trends in other Canadian jurisdictions or internationally?
So we're currently conducting the Canadian trend analysis to see how that compares overall. And one other thing we're actually looking at is, as access has increased, have we seen a reduction in hospitalizations? Because this is a sort of massive investment by the healthcare system into these, and there are some clues that there's a previous paper before access was made broad that hospitalizations start to dip down. So hospitalizations are expensive, right? So if those dip down, it could actually serve as a very easy argument of why these drugs are cost effective, even at the prices they're at. We were also interested if this COVID-19 phenomenon of like hitting, the pandemic affecting testing and thus treatments happened across the world. And so we got data from 8 different countries looking at just crude utilization. And, we see the very similar trends across all different countries, where when the lockdowns occurred in March and April, you see a very sharp reduction across all different countries. some countries, we highlighted that paper, were unfortunately hit worse than us because they were just ramping up their treatments and it came at a very bad time for them. Luckily for us, we'd sort of had those two big bumps, and so we were able to get to some of the populations. The long-term impacts of this, of who's left behind, we have a lot of missed opportunities of people we can't go back to, is still to be known. And so I think there's, we did that paper to kind of send a kind of a spark across. This isn't just a Canadian problem, but globally, if WHO has set these standards, COVID may have really been a hindrance to us achieving sort of the eradication goals that have been set out.
Yeah, not just for HCV, I'm sure for many.
I'm sure for many things, absolutely, yeah.
So what stood out to me in the two graphs that you presented for prescribing and uptake was that there were nice increases in prescribing uptake for the specialties, but not so for the GPs. And I think you touched on this a little bit. Do you have any, can you comment on why you didn't see the same, like it seems to be pretty level for the GPs across?
Yeah, it's, if you really zoom in, it's because the other spikes are so big, you see a little bit of it, but generally what we've seen is a flat line when it comes to GPs and family doctors. And when we try to explore who those GPs are, they're not the general GPs. Like these are GPs who may be built into, like when we worked with our partners in South Riverdale, they're folks that work with them. They work with specific populations. So, they're not the quintessential typical in the community GPs that we would hope would be prescribing. And, I've chatted with a lot of specialists and we've talked to a lot of docs about why are they not keen to prescribe these? And I think even though these drugs they don't interact with many things, they're generally safe, they just feel reluctant, like this is the place of specialists. And I think in many cases, they will more quickly refer, being scared to sort of not know how to handle HCV was the general sense. Now, I would be happy to hear, but that there hasn't been a deeper dive into why that's occurring. And I think perhaps if we try to think about interventions to increase uptake and prescribing among those, I think that's probably the next step, is to better understand what those hurdles are. Now, like we highlighted, there's a whole bunch of tools that have been developed to try to support them in doing so. But sometimes, just creating a tool is half the battle, getting it in people's hands and knowing that this is important is the other half. And I'm sure lots of folks are working on this, but I think that that's the real big missed opportunity. I think being in the community, having the GPs being able to access it or at least know how to help them navigate it will probably help us get to the tougher to treat populations as well.
There's a follow-up question. So do you know of any current guidelines or infographics to help GPs walk through the steps from diagnosis, like the whole cascade from diagnosis to treatment?
That's a real great question. I don't personally know of one. I think I'll instantly be getting on trying to find something after this. If anyone else on this call has one in mind, please do share in the chat or share widely. I don't know, Natalia or Vanessa, if you guys know any, but I don't know of any. If there isn't, this seems like a really great opportunity to develop something.
I have one last question. I think we have time for maybe one or two questions. So I really liked your prescribing distance analysis. As you know, there's multiple steps in, you have to get prescribed medication, but then you have to actually go get medication. Like, have you thought about doing pharmacy distances to see how easily accessible it is for individuals to then fill the prescription?
So it's really funny that you asked that. So actually, when we first, I think to give some of these studies color, the very first study in this was actually co-developed with the amazing folks at South Riverdale, and Zoe, I see is on the call, and like they came up with this question and came to us, and that's what sparked my imagination and the importance of this area. And then the next question came from the ministry, the Hep C Secretariat, and they said, we want to know the distance to pharmacies, like how far are people traveling? And very quickly we realized there's a very big problem. So there's a phenomenon occurring in pharmacies called specialty pharmacies, where specific pharmacies establish relationships and they will ship drugs around the province. And they're very heavily clustered. So a small number of pharmacies will account for the vast majority of prescriptions because they've built relationships with specialty prescribers. They're the ones that have developed, some of them do these great programs. They've done a lot of different things. But what that means is that they're shipping things around the province. So that distance thing is pretty much useless because we don't, there's situations where a person living in Barrie, Ontario is actually getting their drug filled in London, Ontario. And so that distance would look massive, but they are never setting foot in London, right? They're getting that drug shipped to them, but their prescriber and all their treatments are in Barrie. And so there's this strange dynamic that occurs that I don't think, and so as we look through this, we realize that potentially that's not the access issue. I think the access issue is getting that prescription. And then because of how expensive these drugs are, to be very frank, any pharmacy would be happy to fill it. So that's not really, I think it's not getting, unless people have some other problems that I may not be realizing, maybe perhaps like, I can imagine people that are experiencing homelessness may have, if you can't really mail it to them, that might be a hurdle, but I think that generally it hasn't been access to the drugs themselves that's been hurting them. It's getting the actual prescription and the care that you need to get that prescription that's been the problem.
Thanks, Mina. That's really, really insightful. So we're out of time. So thank you to our friends from Katie who posted an online course for clinicians about learning modules for HCV. So please click on that link. And as we wrap up today's PHO round session, I would just like to again thank Mina and Natalia for presenting. I would also like to thank everyone who joined us for today's session. It was great to see such strong participation during such a challenging time for all healthcare professionals. You can expect to receive a brief and anonymous PHO round survey for today's session. Please try to complete this as it really helps us to improve our programming. Lastly, to access past PHO rounds presentations and view confirmed upcoming sessions, please visit the PHO website, head to education events and click on presentations. So thank you all very, very much. And I hope you have a wonderful day and last long weekend of the summer.